Meningitis is classified as an inflammation of the covering of the brain. And in this particular situation, it's inflamed because of infection. I say that meningitis is divided into at least 4 groups. Meningitis in newborns in 2 groups, early neonatal period and late neonatal period. Meningitis in infants and meningitis in children and adolescents. It's also divided according to the duration of symptoms. Acute, is short-lived, subacute for a little bit longer, and then there's chronic meningitis. It's further divided according to the causes of the infectious agents that are causing the meningitis. So you have viral, bacterial, fungal, and parasitic for the main pathogens. And the big one really that you see all the time is aseptic meningitis. But I would say that this is a misnomer, because aseptic implies that there is no pathogen involved, when in truth and in fact, the pathogenic agent is indeed there. It's just that it is maybe caused by viruses, which we do not necessarily identify here in our setting, or the pathogen may be there, but the lab was unable to pick it up because of how the sample was handled. Or the pathogen is there, but because, for example, it's a partially treated bacterial meningitis, we're not able to pick it up as well. There's also the issue as it relates to the irritable, inconsolable crying child who comes to you in the emergency room, and I'm sure you're going to identify these children at some point in your life, either in the emergency room or in your private practices, or even in your day-to-day experiences as you go through life. The irritable, inconsolable crying child is very, very concerning to the mother, because here it is, you have a child who, when the mother lifts the child up, the child cannot be consoled. And what happens is that as the mother manipulates the baby, the spinal column it is itself manipulated. And as you manipulate the inflamed spinal column, then the baby is going to cry. Why? Because of stretching of the meninges, which are already inflamed, and this will cause an infection. This is also a very good way to make your diagnosis, so that you'll know when to do an LP and when to suspect meningitis in the crying child. Now, in early onset meningitis, the etiological agents, as you can see here, are primarily group B strep, Escherichia coli, Listeria monocytogenes, Klebsiella species, and Enterobacter species. Is there somebody who has a microphone open, please? Thank you. These pathogens are primarily live within the maternal genital tract, and group B strep is the most important of them. Then there's meningitis occurring in the child who is more than 2 months of age, and these now reflect community pathogens, Streptococcus pneumoniae and Neisseria meningitidis later on in life. The risk factors and etiology of eosinophilic meningitis, I thought I should mention. Risk factors for meningitis, I should mention, and then I'll speak a little bit about eosinophilic meningitis. So the risk factors are, apart from being a newborn, you can see here in Jamaica where we have a big population of patients who are HIV infected and those who have sickle cell anemia. The pneumococcus, salmonella pathogens, and Haemophilus influenzae type B are very, very important pathogens in these 2 populations. In addition, those who have IgG deficiency, you'll also have the 3 pathogens also being prevalent. Complement deficiency, Neisseria meningitidis, functional asplenia, Salmonella pneumoniae, and Streptococcus pneumoniae. Those who have head injuries will have connections of the head, of the brain through to the cribriform plate and the nasopharynx, and sometimes they may present with group A strep, meningitis, and Neisseria meningitidis. And those who have shunt infections, CNS shunt infections, where the shunt is externalized to the skin, will have coagulase negative staph and staph aureus, as the pathogens, because these are the pathogens that are prevalent on the skin. Those with dermal fistulae will have Staph aureus and E. coli, also important. Now, eosinophilic meningitis is associated with Angiostrongylus cantonensis, or the rat lungworm. And for this one, there were some medical students who came to visit Jamaica some years ago, about 5 years ago, before you got into medical school. They came to us from the Chicago area, and when they went back after their break in February, they were found, about 18 to 20 of them, I believe, were found to have eosinophilic meningitis. And it was linked to the rat lungworm, and the rat lungworm was linked, it was thought, to the fact that they were at this hotel and they all partook of a particular Caesar salad, which was probably contaminated with this lungworm, and as such, they got that. This was widely publicized in the news media then, and also in the literature. Simultaneously, while that was also happening, there were some medical students who were attending to a baby at Children's Hospital, I remember. And when they did the LP and took the CSF and looked at it, the medical student said the CSF is wiggling. So everybody said, well, you know, what are you talking about? But indeed, when they looked, the CSF was indeed wiggling. And it turned out to be the rat lungworm that was affecting the CSF. These very studious medical students went to visit the child in the home. The child lived up in the mountains, not as high as the Blue Mountains, but real high up in the mountains, where essentially the rat lungworm streaks were seen, with the child on the floor of the child's home. So the child, being a toddler, was probably doing hand-to-mouth behavior, and as such got contaminated with this pathogen. We also have bacterial causes for eosinophilic meningitis, syphilis and TB being the big ones. Lymphocytic choriomeningitis as a viral pathogen, coccidioidomycosis as fungi, and then there are drugs and malignancies which will also cause this. Aseptic meningitis can be caused from a wide variety of viral pathogens, as shown here, the enteroviruses and the arboviruses being the top ones. And they also will cause acute viral meningitis, and partially treated bacterial meningitis will cause that too, as will early onset bacterial meningitis, Kawasaki disease, and chemicals. Okay? Subacute and chronic causes include, again, TB, neoplasm, syphilis, and heavy metal poisoning. Recurrent meningitis can present as well with early versus late onset meningitis, as shown here. Now, head trauma, as I mentioned, will cause meningitis, as will congenital anatomical defects, which link the skin or the mucosae of the pharynx or the skin around the anus to the CNS through, for example, a meningomyelocele or an omphalocele or something like that. Immunodeficiencies, as I mentioned before, will also predispose to recurrent meningitis. When we compare early onset to late onset meningitis, you'll see from the table here some of the issues that are common for some pathogens. As you compared this to babies who are less than 7 days of age or children who are older than 7 days. Those who are less than 7 days of age, you'll see that group B strep and Escherichia coli are common because these are coming straight from the maternal genital tract. Obstetric complications are common, as are the pathogen being found in the blood. Hyperthermia is very popular, and the baby will present less with hypothermia, more with respiratory distress, more with apnea, less with irritability and seizures, and of course, very much less with a bulging fontanelle and stiff neck. The mortality is very high. Those who present later on will tend to present with maybe Listeria monocytogenes as a cause. The organism is more commonly identified in the CSF. They are now presenting with fever, irritability, and a bulging fontanelle, and the mortality is less. Here we have the pathogenesis. You remember that the organism presents in the first you have to acquire the organism, it then adheres to the epithelial cells, and then you have colonization, and then this is followed by local replication. At this point, there are either no signs or symptoms, or there may be signs and symptoms in the respiratory tract. And then later, same thing with local invasion. Then the pathogen goes into the bloodstream and causes a bacteremia, and the bacteremia may be asymptomatic. If the child has a septicemia, to present with fever, sweating, malaise, abdominal pain, vomiting, irritability, and lethargy. Meningeal invasion and inflammation will be associated with irritability, restlessness, poor feeding, neck stiffness, a positive Kernig's, and a positive Brudzinski. And then you'll have cerebral edema and a raised intracranial pressure, as evidenced by these signs and symptoms here. The pathophysiology has to do with the fact that you have bacterial products from the gram-negative bacteria, which are released, and then these cause increased cytokines and neutrophils and interleukins to be released. These traverse the blood-brain barrier, cause cerebral edema, and then cause vasoconstriction and cortical necrosis. And then subsequently you have vasodilatation with raised intracranial pressure, CSF outflow resistance, and later on you may even have hydrocephalus. Signs and symptoms of bacterial meningitis in newborns, infants, and children are compared here. Fever may be seen in all three groups. Seizures are seen in all three, but more so in the newborn. Diarrhea in the newborn and infant. Abdominal distension in the newborn. Nuchal rigidity and the positive Kernig's and Brudzinski are seen more commonly in children. When you look at vomiting, anorexia, and lethargy, these are seen more commonly in the newborns and infants, whereas irritability is seen in all three. Nausea and headache is seen in infants and children, whereas neck pain is seen very commonly in the children with neck stiffness. And then they have a potpourri of confusion, photophobia, and hyperesthesia. Clinical manifestations, you will see here for Haemophilus influenza type B and Streptococcus pneumoniae, which is seen more commonly in the older children. If for Haemophilus influenza type B, this is a more protracted or a more fulminant course. Children are very commonly very irritable. They present more commonly with shock and DIC or an obtunded semi-comatose phase state. They will have focal neurological signs, and later on they may present with hearing loss and death, or it can lead to death. Whereas Streptococcus pneumoniae is not such a rapid presentation. It presents more commonly with focal neurological signs and hearing loss and obtunded semi-comatose phase. Haemophilus influenza type B, we don't see that much anymore because we have immunizations which go to everybody in the island. Streptococcus pneumoniae we see from time to time because this vaccine is not necessarily offered to everyone. And the other table you can see breaks down the specificity and the sensitivity of the various investigative microbiological techniques to identify these three pathogens: the gram stain, latex agglutination test, and also how you would identify the fungal meningitis using India ink or the cryptolatex agglutination or ELISA test. Okay, now what is this about? Next slide, please. Next slide, please. Not sure what's happening here, why we're not advancing. Okay. And then here we have now, sorry about that. Here we have now the CSF fluid protein in various diseases. It's mildly elevated in a wide variety of situations: viral meningitis, bacterial meningitis, TB, fungal meningitis, brain abscess, epidural abscess, and so on. It's moderately elevated as well with bacterial meningitis, TB meningitis, and fungal meningitis. And it's markedly elevated in bacterial meningitis, TB meningitis, and fungal meningitis. Here we have the initial antibiotic therapies that are used in newborns. The drug of choice is cefotaxime. Alternate drugs being gentamicin plus ampicillin or ceftazidime plus ampicillin. We try not to use ceftriaxone in the neonatal period because of the problem with hyperbilirubinemia, and it displaces the bilirubin from albumin. In infants and toddlers, we go with ceftriaxone or ceftriaxone and vancomycin if you suspect drug-resistant pathogens. In children and adolescents, we go with ceftriaxone or cefotaxime and vancomycin, or we can go with AMP and chloro. As you get your cultures, your cultures will tell you what your pathogen is, and later on it will also tell you what the antibiotic susceptibilities are. And all you need to do then is to tailor your antibiotic therapy based on your drug susceptibility patterns as shown here. So strep pneumo, the recommended drug of choice is penicillin G, or you can go with ceftriaxone, or you can go with vanc and ceftriaxone if there is significant resistance. Neisseria meningitidis, it's penicillin G. Haemophilus influenza type B, usually ceftriaxone. Group B strep, usually penicillin G. Listeria monocytogenes, it's AMP, and ampicillin and an aminoglycoside. Salmonella, cefotaxime or ceftriaxone, and so on, as shown in the table. For supportive care, we usually go with oral fluids, and we pay very careful attention to the possibility of aspiration pneumonia. Why? The gag reflex can sometimes be involved because cranial nerve 9 and cranial nerve 10 exit from the base of the brain, and when there is edema or inflammation around these nerves, you can have a reduced gag reflex, and it may not be obvious to you, so you have to be very careful as to how you feed these children. You need to monitor them for inappropriate secretion for ADH, and this develops in about 75% of patients. We need to treat them for dehydration, give them anticonvulsants if there are seizures. We need to give them steroids to reduce the cytokine effects. Dexamethasone is what we choose, and we prefer to give it before the child has antibiotics. This has been very much established for Haemophilus influenza type B meningitis. We also need to pay attention to raised intracranial pressure and restrict fluids to 2/3 maintenance, nurse them with their head elevated, and pay attention to the fact that you can have cerebral herniation during the management of these patients. And we need to intubate, mechanical ventilate, and give mannitol in such cases. The complications, they may have fever, which can be prolonged, and this can just be part of the whole process of a meningitis, and so, or it may just be related to subdural effusions or empyema. It can be another focus of the same pathogens, so it could be pneumonia, it could be arthritis or septicemia. It could be related to the drugs that you're giving the patient, or even a nosocomial infection. Most important in our setting, you have to think about a thrombophlebitis as it relates to the IV that you're using. It may need to be changed. Usually we're supposed to change them every 3 days or so, but in our setting, we don't change them until, as we say in medical student parlance, until the line packs up. There are other non-febrile complications, and these include non-sensorineural hearing loss, hydrocephalus, ataxia, brain dysfunction, and the more severe CNS complications include paralysis, hyperactivity, mental retardation, and unfortunately, some patients may die. It can be prevented by giving rifampin or ceftriaxone prophylaxis for those who are exposed to Neisseria meningitidis in the household setting or in daycares, in the military setting, dormitory colleges, and healthcare workers who do mouth-to-mouth resuscitation, which should really not be happening today. For those who are exposed to Haemophilus influenza type B, the risk of secondary disease in persons less than 4 years of age goes up to 1%. And therefore, household contacts should be given prophylaxis. And then, of course, remember you have your vaccines, Haemophilus influenza type B, and again, your pneumococcal vaccines. And for the young people who are traveling for college, we give them the Neisseria meningitidis vaccine. Would there be any questions while I try to upload my other slide? Now, how do I do this now? What do I do? If I close the Blackboard Collaborate, does that mean that you will all go away? I wonder. I hope not. Oh dear, I did. How do I upload another slide? I need to share another slide. Share. How did I do this before? Share files. How do I add another file? Go to desktop. See if I can find another slide. I wonder if there are any questions on this talk before I go on to the other one. We're trying to upload the second talk. Is there any questions, please?
None, Doc. Thank you.
No, none? Okay.
No question.
Right, let me see. All right, let me see if I can. You can see that I am trying my best to navigate and do the best that I can here. Let me see now if I can upload. Where did it go? This one. Okay. Upload. Share. Okay. Your second talk is going to be about COVID-19 in children, and I'm going to pay special attention to the multisystem inflammatory syndrome, which is the disease of note for today. So globally, we know that COVID-19 has taken its toll in the world, in the Caribbean and in Jamaica, with over 190 million cases now and over 4 million deaths for a case fatality rate of 2%. Okay? Community spread is ongoing in several communities around the world, with several countries going through their third and some even going through their fourth waves. There are mutations of the virus with various variants being found in various parts of the world. These variants have over 50% increased transmission, and they're very virulent. Some of these are being described in the UK, in South Africa, in Brazil, and India. And right now, you know, we're hearing about the Delta wave. Every time you turn on the news, that's what you're hearing about. And we are even worried about it being here in Jamaica. Globally, nearly what is this now? 1.6 billion vaccine doses were given up until the 5th of June, right across the world. But these were primarily being done in high-income countries where there has been an up to 90% decline in cases and an over 80% decline in deaths, and hospitals are being emptied of the older patients. Anyway, the role of children and adolescents is unfortunately evolving. Transmission is important. They have rare or mild disease, but when they become sick, they are very, very ill. They have increased hospitalizations, increased morbidity, and increased deaths. And there is this illness called the multi-system inflammatory syndrome of children, where they will present with Kawasaki's disease, intensive care unit admissions. And so I'm just going to spend the next few minutes going through with you very quickly the epidemiology, the pathogenesis, clinical features, management, and prevention of this particular illness. Now, what is the role of coronaviruses and their relevance to children? By now, you would have heard that coronaviruses, there are about 7 different kinds of them, and the first 4 tend to be seasonal, as shown here, and they will give up to 19% of acute respiratory illnesses in children, and 13% of these children tend to be asymptomatic. For those who are symptomatic, up to 46%, they will have co-infections with other respiratory viruses. And then along came MERS, or Middle Eastern Respiratory Syndrome, which appeared in 2012 in Saudi Arabia. 32% of the children there were reported to have household contact. 42% of the children were asymptomatic. Up to 100% of children had fever, and the case fatality rate in adults approached 40%, and in children 6%. And then you had SARS-CoV-1, which appeared in 2002 in China. Up to 80% of the children reported household contact. 2% of the children were asymptomatic. Up to 100% of the children had fever. The case fatality rate in adults approached 17%, and in children it was 0%. And then we have the disease of note that we're talking about now, SARS-CoV-2, which appeared in 2019 in China. 82% of the children were reported to have household contact. 10% of the children initially were asymptomatic. 44 to 50% of the children had fever. The case fatality rate in adults in the beginning approached 3%, but the case fatality rate in children was 0%. And so the transmission in children is felt to be primarily, the illness is primarily felt to be airborne. Spread by small particle aerosols, which linger longer and travel further. And the respiratory samples may be positive for 15 days or more. There's also fecal transmission that is important, with fecal aerosolization, which is important through flush toilets, ventilation systems, and plumbing systems. And in children, their feces may remain positive for quite some time. And, you know, because we take care of children, you know, changing them and so on, we have to realize that strict hygienic measures need to be implemented because transmission can be spread that way. Asymptomatic spread can be from 26 to 45%, and pre-symptomatic transmission, especially with the Delta strain, folks feel that up to 3 days before the persons actually manifest infection with the Delta strain, they are already passing the infection along. Infection is also being spread in families up to 15%. You'll see that the CDC changed their guidelines recently, just 2 days ago, to say that folks should now begin wearing masks when you're indoors because of the threat of transmission in the indoor spaces. Um, And then the prevalence in children worldwide. Early on in China, there were no cases reported in children for the first 12 weeks of the outbreak. In Spain, up to 8.8% of cases in Madrid were found in children less than 18 years of age with no deaths. In Italy, the rate was 1.2% for the first few cases that were reported there, that were less than 18 years of age, and deaths occurred in persons less than 30 years of age were not happening. Currently, what is happening though is that in the United States, they have reported some 3.9 million cases, and with 2% of these children being admitted to hospital, and the death rate being 0.2%. In Brazil, early on in June, they were reporting over 2,200 deaths from COVID-19 in children who were aged less than 10 years of age. And these were thought to be due to the gamma strain, which were thought to be related to increased cases, increased hospitalizations, and deaths. And the same thing was happening in India, where they were now reporting increased cases in children. These children had late diagnosis, low access to timely health care. They were poor. They came from homes where there were inequities. The new variants had a higher viral load, as I said before. Maybe I did, I didn't. The gamma strain, it is said that the load in the nasopharynx is very, 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 very high, over 1,000-fold over compared to the other previous variants. There's also lack of testing and tracking of cases in children. Several of these children are orphaned, and therefore these secondary and tertiary waves are more devastating to children, and more severe cases. At the height of the epidemic in India, we had some 4,000 cases being reported, deaths being reported per day, and over 400,000 cases that were being reported similarly. And in Indonesia right now, I think yesterday they had over 2,200 deaths being reported, what I read this morning. The children are now being found to have severe pneumonia. They're needing assisted ventilator support. They're presenting with type 1 diabetes, and they're presenting with multiple system inflammatory syndrome with significant attributable morbidity and mortality. In the United States, they're also seeing increased hospitalizations in children for COVID-19, and the trends are for those in adolescents, you're seeing nearly a third of them being admitted. 5% of those that were admitted, a third of those that are admitted required ICU admission, and 5% of them required mechanical ventilation. But none of those in this particular cohort died. But these numbers are trending upwards even as we speak. Here in Jamaica, and these are the numbers for the 1st of June, but you know that they're going up. We have over 52,000 cases reported now, and we have over about 1,200 deaths, still for a case fatality rate of 2%. The positivity rate in Jamaica is now trending at about somewhere between 13 and 18%. And you remember that as of just Tuesday this week, we have gone into a new cycle of lockdowns because of the increased hospitalizations, the increased positivity rate, the increased cases that are being reported, and unfortunately the increased deaths. So, this is serious. Here we are with the rates, the age group distribution of COVID cases in children who are aged 0 to 17 years. In Jamaica, 10% of the children, of the cases in Jamaica are children. Of these, 5% are infants, 10% are toddlers, 13% are preschoolers, 36% are school aged, and 35% are adolescents. The death rate is 0.1% in those less than 10 years of age and 0.2% in those aged 10 to 19 years. And here we have the various symptoms for the children, and the symptoms mimic those of the adults. You'll see here overall here in Jamaica, the children present in red with fever, cough, headache, runny nose, and sore throat. Almost all of them will present with those 5 symptoms in all age groups except for infants. Infants tend to present, for 100% of them, present with shortness of breath. Loss of taste and loss of smell is being manifested in the adolescents at a rate of 18% and 14% simultaneously. Vomiting is a predominant finding in the toddlers, the preschoolers, the school-age children, those 3. And then you have, and similarly, you have diarrhea presenting in the toddlers as well. And then you have a wide variety of other signs and symptoms, including nasal congestion, sneezing, weakness, joint pain, eye pain, chest pain, loss of appetite, chills, abdominal pain, muscle pain, and other symptoms. You would ask, why is it that children seem to have gotten mild disease in the earlier cases? And what is being said is that they have lower exposures than adults. They're mostly on holidays. They're on early school and daycare closures. They have already trained their immune systems through the use of routine live viral vaccines. They have cross-protective immunity from the 4 common coronaviruses. They have stronger immune responses, a lower prevalence of risk factors. And then the ACE2 receptors, which are the primary entry points for SARS-CoV-2, this has less binding strength in children as compared to adults. And then it is felt that the lung alveolar epithelium regenerates very, very easily with earlier recovery from COVID-19. So in the first few cases from China, when they did start to identify children, they found over 2,000 cases, and 34% of these were lab confirmed. The majority of the cases, 50% of them were mild, 40% of them had moderate disease, and 5% of them had severe disease. 0.6% of them presented with respiratory failure, shock, multi-organ dysfunction, encephalopathy, cardiac failure, coagulopathy, and renal failure. Here they presented, when you looked at the features for systematic review for children from 131 studies in 26 countries, you'll see that the majority of the children will present with fever and cough. 19% of them are asymptomatic. 20% of them had chest opacities on chest x-ray. A third of them had ground glass opacities on chest CT. 6% had co-infections, and the co-infections primarily reflected mycoplasma pneumoniae in 58% of cases, and a wide variety of other pathogens, including influenza A or B in 11%, respiratory syncytial virus in 10%, and viral pathogens in the rest. Multiple system inflammatory syndrome occurred in 0.14% of cases, and 0.09% of cases died. Clinical features in the United States in children, as compared to what are shown here. They presented with fever and cough and shortness of breath, fever, cough, and shortness of breath, and myalgia at about 20% less prevalence than their adult counterparts. And as shown in Jamaica, they also present with runny nose, sore throat, headache, nausea, vomiting, abdominal pain, and diarrhea. Comorbidities in the United States are shown here. They had chronic lung disease with cardiovascular disease and immunosuppression for 23% of cases. For those who were hospitalized with a comorbidity, you'll see that was 77%. And the children who were admitted to the ICU at that time, all of them had comorbidities. There were 3 deaths in this cohort. And then along comes Kawasaki disease and toxic shock syndrome. Somewhere in the beginning of in the UK, there were hundreds of cases, hundreds of children of all ages being reported in Britain, United States, France, Italy, Spain, and Switzerland with what looked like they call the pediatric multisystem inflammatory syndrome. These children were presenting with abdominal pain, severe hypotension, shock, fever, rash, myocarditis, pericarditis, a multisystemic presentation with intensive care unit admits, with mechanical ventilation and shock. They were presenting with Kawasaki's disease, and Kawasaki's disease, you would have learned by now, presents with prolonged fever, with a rash, with red eyes, swollen red hands and feet, as shown in the pictures here, cervical adenopathy. Patients will present with a coronary arteritis, as shown here, with coronary aneurysms. We give them intravenous globulin, which will reduce the aneurysms from 25 to 5%. And sometimes they will even present with toxic shock syndrome. Toxic shock syndrome is a situation where the patients will present with shock and fever and rash with a multisystem involvement. And the multiple systems that may be involved the heart, the kidney, the lungs, the brain, the blood, liver, gastrointestinal tract, and skin. In the past, this was related to Staphylococcus aureus and group A strep infections, more related to tampons in the ladies or surgical nasal packs in the ENT surgical literature. And then they would identify toxic shock syndrome toxin 1 and toxic shock syndrome toxin 2. Nowadays, it is being linked to COVID-19 in children. In children, we are noticing around the world that they will have a high degree of inflammatory markers. These include high D-dimers, high troponins, high ferritins, procalcitonins, triglycerides, and a positive CRP or ESR. And the SARS-CoV-2 PCR will be positive, or antibodies may be positive. And the death rate in these initial cases was very high. So we have other definitions, other ways in which we can define it. The WHO has come up with definitions, and the CDC has come up with definitions. In brief, these definitions essentially speak to any child or young person less than 21 years of age who has is hospitalized with 2 or more organ systems involved and who has no plausible diagnosis for their fever and multi-organ system involvement, and who has perhaps a positive RT-PCR or serological evidence or antigen test for exposure to confirmed COVID-19 case with 1 or more of these various inflammatory markers. These children should be treated as if they have what we call MIS-C. Looking at the pathogenesis, what happens is that the child will have an early infection. It's and present with an asymptomatic, mild infection, and then they will go on to skip the pulmonary infection phase, mainly because, as I said before, they tend to lack the ACE2 receptors. It is felt that they still stimulate the super antigens and activate the macrophages, and then it stimulates the T cell mediated immune system and stimulates the B cell immune system to stimulate a hyperimmune response through antibodies or a hyperimmune response through the cytokine release storm. And then this now moves on to create the multisystem inflammatory syndrome in children. More recently, it is felt that through zonulin, which protects the gut mucosal barrier, what happens is that the mucosal barrier is opened up, and it allows these hyperinflammatory cytokines to be released into the bloodstream. And in being released into the bloodstream, this is what causes a spike in this multi-system organ system presentation. When you give inhibitors to zonulin, then these patients in this particular study, they did not get this presentation. In the United States, you'll see here that there is a lag. Looking at the blue, there is a lag between when the cases will peak and when the MIS-C cases will develop. The cases are primarily in children aged 5 to 13 years of age, and in the United States they're being seen, and in other countries, they tend to report that they occur more commonly in Black and brown people, and they occur more commonly in males. The systems that are involved include primarily the gastrointestinal system as the top system to be involved, and I guess it is reasonable to suspect that this will be so because as I said, the pathogenesis links it to the GI tract. And then the cardiovascular system is involved at 80%, hematologic 75%, mucocutaneous system 74%, respiratory 70%. 80% of these cases need ICU care, 48% need mechanical ventilation and vasoactive support, and the death rate is 2%. Looking at the children, 115 children, median age is 8 years, 62% of them are male, 73% of them are previously healthy, 70% of them will have evidence of SARS-CoV-2 RT-PCR positivity or antibody positivity, and the rest of them would have had exposure to SARS-CoV-2 within the last month. And up to 92% of them had elevation in the 4 inflammatory biomarkers. They are being treated with intravenous gamma globulin for 77%, glucocorticoids or steroids in 49%, and 20% of them had the IL-6 inhibitors that were treated. And here we have again the same summary from a different study. And here again, another 783 cases from a more recent study, again showing the same features. Here at the university, we have seen about 80 children who are less than 16 years of age with COVID-19 here over a 1-year period. Half of them were hospitalized. And among those, about half of them had MIS-C, multisystem inflammatory syndrome of children, and they were treated appropriately. 5% of them were admitted, 2% of them died, and the 95% of them were discharged and were sent home. Other pediatric issues to pay attention to as it relates to COVID-19 is the underdiagnosis of pediatric COVID. We have to realize now that we have to identify the children, especially since we're hearing now that children are now being prepared to go back to school in September. And the other issue too is that children are presenting now with what they call long COVID, meaning then that they may be asymptomatic initially or may have mild COVID. And then what happens is that they go on to have long COVID, where they have fatigue, muscle and joint pains, headache, they're not sleeping well, they have respiratory problems, they have palpitations, and they have neurocognitive effects. So those are things to think about. They're also worried, as I said before, as it related to variant strains of concern with increased virulence. The one that we're talking about is the Delta strain, which we think is probably circulating here in Jamaica, bearing in mind that our borders are open, wide open with the United Kingdom and also with the United States. We also have the Lambda strain, which we need to think about as well. It's not here yet. It's a variant of interest, but it's still something to think about. And as you would well know, they are also vaccinating children with the Pfizer vaccine, with the Chinese vaccines, and other vaccines to come on board as it. So in conclusion, COVID-19 in children is primarily a mild disease. Asymptomatic cases seem to be prevalent right across the world. And most children just have fever or cough or don't have anything at all. And very few of them require hospitalization. However, there is a small subset of children who will present with the multisystem inflammatory syndrome, and they present with shock, and some of them will require ICU admission, and some of them will die. This is primarily being seen now in Brazil, in India, Indonesia, and in the United States, and it's being linked possibly to the circulation of new variant strains. We need to pay attention now to the fact that the Delta strain is highly infectious and carries a higher morbidity, not only for children, but for adults as well. And therefore, we must pay attention to physical distancing and preventive behaviors. And vaccines are also becoming important. And the clinical presentations and outcomes in hospitalized children are now being explored also here in Jamaica. So I'm going to stop there. So it is 10:15. I wonder if we could take a 15-minute break and then come back. Do we have time to come back at 11 o'clock and I could go through the last talk with you, maybe in a half an hour? Can you manage that? Is there anyone speaking? Or you want me to go straight into that talk or what? Is there anybody speaking for the group?
Hi, Doc. Your
Yes.
next lecture, are you emerging viral infections?
Yes, I need to do another talk on
Okay,
this.
yes. Can we take 15 minutes, please?
Please, sorry?
Can we have 15 minutes break?
You take the 15-minute break.
Yeah, thank you.
Okay. So we come back at, it's now 10:17. Oh my goodness.
Yeah.
3 minutes went very fast. Okay, so I'll try and set up now for 10:30 or shortly thereafter. Okay.
Can you stop
Thank
the
you so much.
recording here as well?
What?
Can you stop the recording here as well?
Oh, you mean stop the recording now?
Yeah.
How do I do that again? Recording in progress. Stop recording.